Hi everyone, my name is Dr. Michael Baca-Atlas and I'm a family medicine physician and addiction medicine specialist. I'm here to talk to you today a little bit more about tobacco pharmacotherapy or medications for tobacco cessation. So remember, like alcohol and opioid use disorders, there is such an important role of comprehensive treatment, and that includes both medications and counseling. And so we have actually really strong data from large meta-analyses for tobacco cessation that really the gold standard is the combination of pharmacotherapy and counseling, but we're really here to focus on medications today. Just like our other substances that patients may use, that tobacco and nicotine use leads to changes in the brain, including various neurotransmitters. And so just like we have an opioid withdrawal syndrome or an alcohol withdrawal syndrome, there's also a nicotine withdrawal syndrome. And so our patients who are using opioids, they only may be using that substance a few times a day. But remember, our patients with tobacco use, they may be using a cigarette or other tobacco product 5, 10, maybe even 15 times or more a day. And that's because the half-life of nicotine is right at about 2 hours. So what's happening during the day is that these levels of nicotine in the brain are oscillating up and down. And what we see happen is low dopamine levels, low serotonin levels, and also low norepinephrine levels. And so what does that mean for our patients? Well, they develop irritability, emotional dysregulation, and even poor attention. So this can make it difficult to function in maybe jobs, maybe as a parent, and this can last up to 2 to 3 weeks, if not even months to years. This is why, again, we're talking about pharmacotherapy here, is that the rates of going cold turkey are less than 3% success rate. So it just doesn't work, and it makes sense because of what's happening in the brain and why medications play such a crucial role. Before we dive into talking about the FDA approved medications for cessation, we must remember that smoke in combustible products accelerates the metabolism of many substances and drugs that we prescribe. And it's not the nicotine. I can't say that enough again. It's not the nicotine. It's what's responsible for that are what is known as polycyclic aromatic hydrocarbons. So we need to understand the role that smoking has on other pharmacotherapy, as I mentioned before. And these may be medications that you're commonly prescribing because, again, in addiction medicine, we work with patients with behavioral health issues, physical health issues. So some of those medicines include antipsychotics like olanzapine, clozapine, and haloperidol, other medicines like oral contraceptive pills, beta blockers, including propranolol, and even our benzodiazepines and opioids. The tobacco smoke causes less sedation and analgesia. So when people stop smoking, you may notice that people can experience side effects or adverse effects because now that smoke is no longer breaking down that particular medication. Onwards and upwards to our medications that are FDA approved. So we have really 2 different ways to think about it. We have our nicotine replacement therapies. There are 5 FDA approved products, and that includes nicotine patches, gum, lozenges, a nasal spray, and a nicotine inhaler. And also we have prescription medications, and those include Wellbutrin and varenicline, also known as Chantix. One thing you may not be aware of is that there are some second-line, not FDA-approved therapies, clonidine and nortriptyline, that we use off-label. And many of you may be familiar with nortriptyline because of its effect that it has on being used for migraines and sometimes even insomnia at nighttime. And also many of us have used clonidine for opioid withdrawal, and also it's used for other behavioral health conditions as well. When we think about how to best prescribe these medications, there are really 2 main strategies. First one for us to talk about is standard of care. Okay, what that means is that no patient should ever really receive less than that. Of course, as if they decline, medications, or maybe they've had an adverse effect or an allergy. But the mainstay treatment is a long-acting nicotine patch plus some form of short-acting nicotine replacement, like gum or a lozenge. And those should really always be combined together. And the second standard of care therapy is actually varenicline. So both of these have the highest abstinence rates, and we should be offering these different medications to our patients really firsthand. Now, the other strategy that I want to come back to is what's known as innovative strategies for prescribing medications. And what I mean by that compared to standard of care is that the data and the evidence is just a little bit less. We have less robust randomized controlled trials, less numbers of patients enrolled in these studies, but we do know that there are ways to modify the therapies that are FDA approved to to sometimes benefit our patients. So one key takeaway from that is that some of our patients may benefit from combination therapy strategies. They may require a nicotine patch, maybe nicotine gum or a lozenge, and maybe stack on some varenicline as well, and that would be sort of your combination therapy strategy for that patient. Pharmacotherapy alone, it does not address several things. So it does not address coping skills, stress management, triggers, social support, and even motivation or planning. So again, medications alone can sometimes help people decrease their overall use, but again, the most effective strategy that has been studied is combination strategies, which include both the medication aspect as well as the counseling piece to address some of these issues that we've talked about. I'm so glad that you're able to join us today, and thanks so much.